All right, let's talk about one of the most fundamental and honestly one of the most critical things we manage as nurses, fluid and electrolyte balance. Have you ever looked at an EKG and wondered what it's really trying to tell you about a patient's hydration? Or why a seemingly small shift in an electrolyte can become a full-blown medical emergency? Well, we're going to break all of that down so you know exactly what to look for and how to act.
So here's our game plan. We'll start with the core concept of the body's balance. Then, we'll hit the two big extremes, fluid overload versus dehydration. After that, we'll dive into the 5 essential electrolytes, decode what the heart's EKG is telling us, and finally, wrap it all up with your nursing action plan. Let's get right into it.
Okay, first things first. We're starting with what I think is the most important principle in all of nursing. It's not just about memorizing a list of things to do. To be a truly safe and effective nurse, you have got to understand the why behind every single intervention.
This right here, this is our guiding principle. It's all about being a clinical detective. You know, knowing a patient's sodium is high, that's just a piece of data. But understanding why that specific IV fluid is ordered to correct it, that's what stops you from causing neurological damage. That's what saves lives. It's all about the rationale.
So let's jump into the most common imbalance you are absolutely going to see on the floor, fluid volume. We're going to look at the two opposite ends of this spectrum. What happens when there's way too little fluid, and what happens when there's way too much.
First up, we've got fluid volume deficit, or FVD. Just think dehydration. This happens anytime fluid output is greater than fluid intake. We're talking vomiting, diarrhea, a hemorrhage, or even just profuse sweating. This puts a massive strain on the whole body, making the heart pump harder and faster and basically starving the kidneys of the fluid they need to do their job.
And on the other side of that coin is fluid volume excess, FVE. This is where the body is just holding on to too much fluid. It's often because of a bigger problem like heart failure or kidney failure. All that extra fluid and sodium starts to pool outside the cells, flooding the lungs and tissues, and creating a completely different but just as dangerous set of problems.
Now this is where it gets really interesting, because you see the body telling two different stories. With FVD, the tank is empty, so blood pressure drops and the heart races to compensate. But with FVE, the tank is overflowing. Blood pressure is high, but the heart rate still increases, giving you this strong, pounding, bounding pulse as it struggles to pump all that extra volume. With FVE, you'll hear crackles in the lungs, you'll see JVD. With FVD, you'll see that classic skin tenting. These are the signs you can't miss.
Okay, now let's meet the key players, the little chemical messengers that run the body's entire electrical system, the electrolytes. We're going to look at the big 5 and see what happens when their levels go haywire, either too high or too low.
Let's start with calcium. The big thing with calcium is its effect on our muscles and nerves. When it's too low, hypocalcemia, everything gets twitchy and irritable. The mnemonic to remember is CATS, C for convulsions, A for arrhythmias, T for tetany, and S for spasms. But when calcium is too high, hypercalcemia, it's the opposite. It sedates the body, leading to muscle weakness and even constipation.
Now, magnesium is all about excitability. I like to think of it this way. Low magnesium, or hypomagnesemia, makes the body really irritable and excited. You'll see hyperactive reflexes, maybe even seizures. But high magnesium, hypermagnesemia, makes the body too cool and relaxed. And while that might sound nice, it's actually really dangerous. It can cause low blood pressure and even shut down the drive to breathe.
Okay, listen up, because potassium is a big one. It's all about the heart. Both too little and too much can trigger deadly arrhythmias. For high potassium, hyperkalemia, you absolutely have to know this mnemonic: murder. M for muscle cramps, U for urine abnormalities, R for respiratory distress, D for decreased cardiac contractility, E for EKG changes, and R for reflexes. Burn that one into your brain.
When you think sodium, I want you to think brain. It's that simple. See, water always follows sodium, so any imbalance causes fluid to shift into or out of our brain cells. With low sodium, or hyponatremia, water rushes into the brain cells, causing them to swell. This leads to confusion, seizures, even a coma. With high sodium, the opposite happens. Brain cells shrink, causing intense thirst and lethargy. Both are huge neurological emergencies.
And finally, we have phosphate. The number one thing to remember here is its relationship with calcium. They're like two kids on a seesaw. If one goes up, the other has to go down. So if your patient's phosphate is low, you can bet their calcium is going to be high.
This is so important because if you're treating high phosphate, you have to be watching that patient like a hawk for signs of low calcium.
Okay, so we know the theory, but how do we see these problems happening in a real patient right now? Well, the heart is incredibly sensitive to all these shifts, and it often sends out the first and most urgent distress signals. Knowing how to read those signals on an EKG is an absolutely vital skill.
So how does the heart talk to us? It speaks a language, and that language is the electrocardiogram, the EKG. The EKG tells the story of the heart's electrical journey with every beat, and electrolyte imbalances create very specific, very recognizable patterns in that story.
Let's look at potassium again. When potassium is dangerously high, hyperkalemia, it makes the heart muscle cells reset or repolarize way too quickly. And that super fast reset creates the classic, terrifying signature on the EKG, a tall, peaked T wave. Seriously, if you see a T wave that looks like a tall, sharp tent, that is a medical emergency. Low potassium, on the other hand, can give you ST depression and this weird, abnormal little bump called a U wave.
Now, calcium has a different job. It directly affects the timing of the heart's muscle contraction. So too much calcium shortens that contraction phase, which you can see on the EKG as a shortened ST segment. And you guessed it, too little calcium does the exact opposite. It prolongs it. This just goes to show how critical calcium is for the perfect timing of every single heartbeat.
Okay, so you've assessed your patient. You've pieced together the clues from their vitals, their labs, and that EKG strip. Now what? Now it's time for the action plan, and we're going to focus on one of the most powerful tools in our arsenal for fixing fluid problems, diuretics.
Think of this table as your diuretic cheat sheet. When you're about to give one of these, there's one question you have to ask yourself. Does this medication waste potassium or does it spare it? Loop diuretics like furosemide are workhorses. They're super potent, but they also make you lose a ton of potassium, which can be dangerous. On the flip side, potassium-sparing diuretics like spironolactone are less powerful, but they are absolutely essential when your patient's potassium is already low. Knowing that difference is non-negotiable for patient safety.
And here's how you put it all together. This is your thought process. Step 1, always, is to fix the underlying cause. If your patient is vomiting, just giving them IV fluids without an antiemetic is like trying to put a Band-Aid on a geyser. It's pointless. Fix the root of the problem first. Then, you can move on to conservative measures, monitoring them closely, and finally, giving medications if you need to.
And let me leave you with one final, absolutely critical safety check. Diuretics work inside the kidneys. So if the kidneys aren't working, if your patient has renal failure or isn't making any urine, giving a diuretic is not only completely ineffective, it can actually cause more harm. Always, always check kidney function before you push a diuretic.
So we'll finish with this thought. Being a great nurse really means being a great clinical detective. It's about listening to the story that a patient's body is telling you, through their symptoms, their lab values, and even through a simple EKG strip. When you start paying closer attention to all those subtle clues, you stop just being someone who does tasks. You become someone who provides truly life-saving care.